Good morning, everyone. Welcome to today's meeting. I would like to welcome you all here today. For those who don't know me, my name is Khaled El Sayed. I'm chairman of GESR organization. Before today's presentation, I would like to present Professor Yulia Kirova. In today's talk, Dr. Kirova will cover the radiation therapy in multidisciplinary management of breast cancer. Professor Kirova is a senior radiation oncologist and associate professor in the Department of Radiation Oncology at the Institut Curie in Paris, France. She is involved in patients' care as well as in clinical and translational research and participates in development of new treatment protocols and new radiotherapy techniques. Professor Kirova has been involved in teaching nationally and internationally as a teacher in annual ESTRO and teaching courses as well as ESSO, and in addition, she is an expert in NCI France and Cooperative Group of Radiation Oncologists. Professor Kirova is also Vice President of FROG and a member of International SIOG Radiotherapy Task Force and a member of various national and international organizations. She is also active member in steering committee of International Lymphoma Radiation Oncology Group, and she was a visiting expert in Shanghai in China between 2016 and 2018. And since 2018, she works also as a visiting professor in Harvard DFCI Hospital at Radiation Oncology Department for breast cancer and hematological malignancies. Yulia Kirova is also BI in different national and international trials, and she is involved in translational work of Institut Curie in Paris, Orsay. She authored and co-authored around 315 articles on PubMed and several book chapters. Please welcome Yulia Kirova. Professor Kirova, please proceed.
This is nice pleasure and honor for me to be in Egypt. Unfortunately, virtually today, but I hope to visit Egypt again because I have been, and this is very nice country and the people are wonderful. Therefore, I want to welcome all of you also to this course, and I will try to take with me today a small piece of the French radiation oncology history and the French tradition. And we begin with the presentation of my institution. You can see these people here, the only family all over the world with 5 Nobel Prizes. You can see Pierre and Marie Curie, who received the first Nobel Prize in 1906 for the physics. Then Madame Curie had the second one in chemistry. It means 3 Nobel Prizes already, and 2 Nobel Prizes after this for Irene and Julio Curie, who worked in the artificial radioactivity. Therefore, if you are coming in Paris, you are very welcome to come in the Institut Curie to visit us, and we can visit also the museum with very rich history of radiation oncology. Then to continue with the French tradition, we will go to the treatment of breast cancer. Khaled, did you give me the hand because it doesn't move for the first time?
Okay.
My slides.
Yes. Now, can you click on your slides?
Yes,
yes,
it works. Yes, you are the chief.
Yeah.
And if we begin with the history of the treatment of breast cancer, you can see here one of our very first radiation oncologists. This is Dr. Chikuto, who designed his treatment of breast cancer in 1908. He was radiation oncologist in Bordeaux, And you can see here a lot of things already very modern for this time. This is the Röntgen tube, and something very also traditional in France is to keep the breast. Therefore, here you can see the breast conserving radiotherapy, the breast conserving treatment of the breast cancer with radiotherapy. And here he is looking at his watch, and here it is the time of working of the machine. It means that there was already breast treatment 1 century and 15 years before this talk. It was already breast conserving treatment with radiation oncology, and there was also fractionation, and this is something that illustrates that the idea of the place of radiation oncology in breast cancer treatment is not something so modern. It is something very, very traditional. And here you will see the plan of my talk. We will begin with the epidemiology, genetics, and screening. Then we'll speak about DCIS because the radiotherapy is a major partner in the treatment of DCIS, ductal carcinoma in situ. Then we'll speak about the post-mastectomy radiotherapy with or without lymph node irradiation. And this is very hot topic when we are discussing the patients during our multidisciplinary meetings. Then we'll speak about this mastectomy versus breast conserving treatment with radiotherapy. It will be nice if there is some surgeons because they need also education about the place of the breast conserving surgery. Whole breast radiotherapy after breast conserving surgery for the invasive cancers this time, because we begin with DCIS, but then we'll move to invasive cancers. Then we'll speak about fractionation trials, because we are moving from 6.5 weeks to 5 fractions 1 week currently, and this is also a hot topic. And then we'll speak about toxicity, future directions, and technical considerations. And all of these subjects will be interesting considering your place as radiation oncologist involved in this treatment of this patient. And we'll begin with these large statistics about the incidence at left side of breast cancer and mortality at the right side. And you can see that this is one of the sites of cancer that we see mostly in women. This is the first cancer in a lot of countries in Europe in the women, and with very, very high incidence. This is about 60,000 patients, for example, in France, and the mortality currently is going down. You can see here the statistics about Western Europe, Northern America, and also we have statistics for Africa, obviously Asia also. Obviously, the incidence is probably lower, but it's still a problem in terms of mortality. And you can see here the therapeutical results in the treatment of breast cancer. But last years, we improved dramatically these results with the new modern radiation therapy techniques, new protocols of radiotherapy, and also because we have also new molecules and new targeted treatments and the systemic treatment. But we'll begin with the risk factor of breast cancer as lifestyle, and also the most important risk factors in the breast cancer, we know this, are the mutations BRCA1 and BRCA2 mutations. And if we look at the lifestyle factors, they can be modified to reduce the breast cancer incidence. For example, this is the example with UK statistics. The alcohol, but I know that in Egypt it's not a problem. It will be kind of 6% the use of alcohol. Something that we have also in France in last years, this is the overweight and obesity. It's not all the life, but it's mostly after the postmenopausal women. This is also a kind of risk factor to developing breast cancer. We have less and less physical exercise because we are working all the time with our computers, but you can see that the risk is not so important. Postmenopausal hormones is also risk factor recognized already. Ionizing radiation, this is when the patient was irradiated, for example, in young age for Hodgkin disease or for contralateral breast cancer with non-adapted technique. Therefore, this is also a risk factor to develop breast cancer. It depends also from the profession, professional risk factors, occupation, and reproduction. Reproduction, because we know that more children with more breastfeeding will decrease the risk of breast cancer. But you can see all these risk factors will be only 27% participating in the risk as risk factors of the breast cancer. This is only theoretical. Lifestyle changes can only make a modest contribution to reduction in breast cancer, because in your current practice, sometimes you have women who will say to you that, doctor, I'm eating only healthy food. I am not drinking. I'm not smoking. I am doing a lot of physical exercise. I have 5 children with breastfeeding without problems. And I developed breast cancer. Therefore, as I said, the lifestyle changes can contribute to reduce the breast cancer, but it is not so important as these 2 genes we'll see. You can see here the BRCA1 gene, publications realized between 90 and 94, but the definition of gene was definitely done in 1994. Then you can see the second gene, BRCA2, and we know that these mutation carriers, they have a higher risk to develop breast cancer in their life. And we will see if we need or not to adapt our treatment to this mutation. Why it's important to know and to have this information? Not only since last ASCO meeting, because the PARP inhibitors probably will work in BRCA1 mutation carriers. We need to know this as radiation oncologists because the BRCA gene products are involved in the double-strand break repair mechanisms, in the cell cycle checkpoint control. They participate in the regulation of the apoptosis. They are really caretaker genes, and they are involved in the maintenance of genome integrity stability. And therefore, we know that these patients are with increased risk to develop breast cancer. But in some countries, and this was a bad idea in the United States to propose mastectomy to all patients, because in this case of patients, we have not only mastectomy as kind of protection, but we have also another therapeutic and diagnostic arms. You can see here in the case of breast cancer, there is prevention. Sorry for this, there is a problem with my screen once more. Sorry. Khaled.
Yes, Julia.
I lost my screen.
I think so. Can you close it?
It's okay.
Yeah, it's okay.
Do you see me?
Yes.
Okay, perfect, perfect. It was technical problem. And you can see here that the screening of these genes is very important. And obviously, we can follow the family history in these patients. There is also chemoprevention, and this is something we developed in the last years. And also biological prevention is also tried in the protocols. And our question here as radiation oncologists is the breast conserving surgery and radiotherapy is possible and BRCA mutation carriers, or we have do all of us the same thing as Angelina Jolie, bilateral mastectomy? We have already enough data in the literature. We have retrospective non-matched studies. We have retrospective matched studies to have decreased bias, and we have also prospective studies. And if you look in the literature, here you can see the ipsilateral breast recurrences in patients treated with conserving breast surgery followed by radiotherapy, in patients with BRCA1 or 2 mutations. And when you are looking here, in all cases, the ipsilateral breast recurrences are not higher as incidence. There is only one study, and I will show you the data of this study, where there is higher risk of recurrence in this population patients. In the other studies, Rotterdam, the multicentric study of Lori Pierce, the Curie trial in 13 years follow-up, median follow-up, also Memorial and McGill Hospital, 10 years follow-up, there is no difference between carriers and non-carriers in the ipsilateral breast recurrences. And the Yale trial was the only one which has shown that there is increased difference between carriers and non-carriers. But in this trial, published by Dr. Hafti in 2002, there was important bias because there were only the study was driven only on the patients who were very young, younger than 42 years, and only the patients who were alive during the study. Therefore, this bias was important because we know that in young patients there is higher risk of recurrence, and we'll speak about the boost and how to decrease this risk after this. But also because only patients who were alive, therefore this was the only study and there is important bias. In the other studies, we have shown that there is no difference in recurrence rate. It means that if you have patient with mutation, you can treat her after discussion with breast conserving surgery followed by radiotherapy. What is the problem in these patients? Here you can see that all of us, we are agreeing. The problem is the risk of contralateral breast cancer. The new breast cancer, because they, in all cases, they will develop more contralateral breast cancers than the general population. Therefore, it is very important for this population of patients to propose screening and follow-up. For example, in France, all these patients are seen once per year with MRI, clinical examination, mammogram, and ultrasound once per year. They are followed because if we detect the contralateral breast cancer at early stage, obviously we will have 99% survival in early stage breast cancer. Therefore, it's important to do the screening and follow-up in this population of patients. And here you have all literature about BRCA1 and 2 mutation carriers. And you can see here the Lori Pierce trial, who is the largest series with more than 600 patients. And our study with the longest follow-up with 13.4 years median follow-up. We have shown that there is not increased recurrences in this population of patients after breast conserving surgery. Therefore, to keep in mind, take-home message, we can propose to these patients and share the treatment decision, and this is important point. At the same time, we have some prognostic factors for recurrence. For example, this family history is one point, but also the age. As I said to you, the age is most important thing. The tumor size and stage, obviously. If there is lymphovascular invasion, if there are surgical positive margins, and also it's important to evaluate the quality of local regional radiotherapy and the adjuvant systemic therapy. For example, Laurie Pierce has shown that, for example, the use of chemotherapy in this population of patients was important prognostic factor for the survival. But also it is related to the biological subtype, and it is important to evaluate the characteristic of the tumor. What we can say about the prophylactic mastectomy? It was shown that this can reduce the risk of breast cancer incidence or recurrence, but there is not enough data to support an improvement in survival in patients affected or uninfected of this mutation. The complexity of the problem needs a multidisciplinary approach within the context of a family cancer clinic. As I said to you, usually we have discussion with these patients, and also we explain everything, the positive part and the negative part of mastectomy. Why it is important? Because we have to share this discussion with our patients, because it is shown also with a lot of data in the literature that the patient anxiety, sometimes the quality of life after mastectomy is really decreased. There is sacrificing cosmetic, body image. In a lot of cases, it is reported there is the patient sacrificing their sexuality. BRCA1 and 2 mutation carriers who underwent prophylactic mastectomy reported to have less favorable body image. 70% of them reported changes in their sexual relationships, and therefore we are logically discussing with the patients. And just for the small history, it's true that it was pretty modern. It was article in Times in United States to do bilateral mastectomy. It was the case, as we discussed, of Angelina Jolie. But this lady, she came in Curie Institute to visit our department of genetics and to discuss with our geneticians, because we have this long tradition to keep the breasts and to keep the life of our patients. What we can do for these patients as well for the detection of breast cancer earlier. This is the breast cancer screening. And if we have developed breast cancer screening, obviously we'll detect the breast cancer at early stage. Why it is important? Because currently we have very early detections at stage of DCIS, for example. It's important for the DCIS to have the clear characteristic of the tumor, if this is cribriform, solid, comedocarcinoma, if there are necrosis, if there is microcalcifications. Obviously, it is important to do this for invasive cancers. And for invasive cancers, we look at the biological markers, ductal or lobular. We look at the mitotic index and Ki-67 because the proliferation is a factor of response of systemic treatments, as well as for radiation therapy, estrogen and progesterone receptors, obviously for everybody, HER2 expression. And now, for cases we have not discussion, we have some cases limited as indication for chemotherapy. We can use Oncotype DX, MammaPrint, or PAM50. It depends what you have in your country. But for example, I have patient we discussed yesterday, PT2 tumor, grade 2, but estrogen, progesterone receptor positive, HER2 negative. It's pretty large discussion if she needs or not chemotherapy. In this case, we'll do, for example, PAM50, and we'll decide if there is benefits to do chemotherapy in this case. Obviously, the pathological report will give you information about the lesion size as well as the margin status, because as radiation oncologists, we are pretty interested of the margin status. And these are factors we are looking for, because if you have necrosis in DCIS, you need boost. If you have involved margins and your surgeon say, I cannot do new resection, you have to do boost. If the lesion size is 1 millimeter or 10 millimeters against 4 centimeters, it's true that we'll discuss also irradiation with lymph nodes or with some larger fields. This is also an important factor to decide the kind of our volumes of irradiation. And as I said to you, also the proliferation. And let's begin with the ductal carcinoma in situ. This is 15% of breast carcinomas, especially if you have screening programs, you will see a lot. 20% of those are detected by mammography. Currently, we have 40 to 50% high grade at diagnosis, and it is not obligatory precursor of invasive carcinoma. There is also prediction of difficult clinical behavior at diagnosis. Therefore, it's important to have more information about your ductal carcinoma in situ before to begin treatment. And this is the thing we are working with our residents at our multidisciplinary meetings to evaluate the grade of the DCIS, and I will show you why it's important for us, because low grade, you can discuss participating in the projects of desescalation of the treatment after breast conserving surgery. In high grade, you need to treat whole breast and follow this by boost, and this is the difference between low, intermediate and high grade, and this is important part of our work. We have a lot of cases with association between the grades. You can see here low grade, it's about 17.7% in our experience, intermediate 31.4%, and high 50%. But look at the associations. You have sometimes association between low grade and intermediate grade, and this is pretty nice because here you can discuss desescalation. But as I said to you, if you have intermediate and high grade, here you are speaking of real breast conserving surgery followed by radiotherapy in good condition. Therefore, it's important to know the histological type. The other very important point are the margins. The margin status is shown as a risk factor of recurrence in this kind of tumors. And here you can see the classification of our pathologists. Dr. Sigal Zafrani was our chief pathologist for years. 1 millimeter is known as close margin, but is safe margin. You can have also between 1 and 2 millimeters as close margins, but now we recognize that it's nice to accept 1 millimeter, because before for France it was 2 millimeters minimum margin for the in situ tumors. Now it's about 1 millimeter. Then you have margin close. The tumor is very close, less than 1 millimeter. Then you have focal involvement, and you can see here the tumor is in contact, minimal involvement, and then extensive involvement. Why this is important for us? Because 1 millimeter or close margin, we will discuss the boost, especially in ductal carcinoma in situ of high grade. But if you have close in young lady, in this case, we discuss with our surgeon that we have to do re-excision. And if you have group 3 or group 4 or group 5, in this case, there is indication of re-excision. And if the breast conserving surgery is not possible with good aesthetic result, obviously, in this situation, you can propose also mastectomy to this population of patients. The treatment options are, as I said to you, mastectomy, huge tumors, large invasion, impossible to do something with good result. Obviously, breast conserving surgery and radiotherapy. We have also series in Curie for patients who refused surgical procedure in this population. We proposed and we have pretty good results of radiotherapy, exclusive radiotherapy with boost to the tumor. There are some countries who propose no radiotherapy but hormonal treatment, or we can say nothing and we follow the patient. This is not a real practice, but there is a protocol in Holland running for 5 years now, nothing and just follow up of the patient versus treatment. And unfortunately, this is the work study. Unfortunately, it doesn't work very well because the patients prefer to be treated and have less risk of recurrence. And here we have really a lot of evidence-based. We have large retrospective studies, we have prospective trials, and I will show you all these data. And we have meta-analysis, the people of Oxford, who have taken all these studies, but the individual patient data, and they actualize their results every 5 years. Here you have the large prospective trials before the last one. We have the American trial, B17. You have ERTC trial, when we compare this breast surgery with negative margins, with radiotherapy and without radiotherapy. There is Swedish trial, and you have UK and Australian trial also. And as you can see, there are more than 4,000 patients included in these large prospective trials. And I have given to you here the results of all these trials. It's more easy to read. And you can see that with the best surgery, with large margins, surgery only is in green, light green, and you have at the right side surgery with whole breast radiotherapy. And you can see in all cases, you have double of recurrences in these trials if you do not do radiotherapy after this surgery. And as I said to you, this was large surgical procedure, no involved margins. There are some studies with margins larger than 1 centimeters. And the result is here. The radiotherapy has its role in the treatment. And when we look the results of these 4 trials in the meta-analysis of Oxford, there is huge and significant difference between the breast conserving surgery versus breast conserving surgery and radiotherapy. You can see here the results, long-term results, more than 3,700 patients with follow-up close to 10 years in this study. And the result is that we need radiotherapy for these tumors. And we are looking at all these trials. This is positive in all trials. And when we are looking at the age of diagnosis, it's true that the age is important, but it's obviously the radiotherapy is doing better, as well as the surgery. Tamoxifen, with or without tamoxifen, it depends because it was included in some trials, but then we will speak the place about hormonal treatment in these tumors. No difference in detected method, no difference in margin status. In all cases, we have benefits of the radiotherapy. It is also related to histological grade, nuclear grade, comedonecrosis, architecture, as well as clinical tumor size and pathological tumor size. And it means that this is important, and we have to evaluate now the risk factors for breast recurrence to propose probably something more than only radiotherapy to the breast. And it was shown already the young age, factor at risk, involved margins, as we discussed, high grade, necrosis, and tumor size. But why we are discussing if we need radiotherapy or not. It's about this data published because there were some reports with toxicity at long term. For example, when we are looking at the last trials, the toxicity is pretty low. 7-year toxicity in the last RTOG trial. You can see that it's mostly skin toxicity. And here you can see grade 1 and 2 mostly, less grade 3, about 4% skin toxicity. It seems that with the new techniques, and we have not really skin toxicity in this population of patients. When we look, sorry for this, about the Netherlands cohort trial with a longer series, patients less than 75 years, more than 10,000 patients, a breast conserving surgery plus radiotherapy or mastectomy with or without radiotherapy, median follow-up 10 years, minimum follow-up 5 years. Here, the people, our colleagues from Netherlands, they reported that there was no increased heart morbidity and mortality after treatment for DCIS. And when we look DCIS versus no DCIS, in comparison of the risk, or radiotherapy versus no radiotherapy, or radiotherapy left versus right breast, there is no difference in the toxicity. Therefore, we must understand that the radiotherapy is a part of treatment, and with the new techniques, we are not so toxic. When we look the larger data of SEER, 12 states in United States, more than 50,000 patients, radiotherapy in 46.3% of the patients. It was written that after treatment of DCIS, they detected less lung and colorectal cancer. This is very nice. I don't think that it's our fault to have less lung and colorectal cancers, but it's pretty good to understand. Second cancers related to radiotherapy is very low. This is about 0.8. In our Curie series, we detected 0.48% at 15 years. It means 35 radiation-induced sarcoma in 14,000 patients we have treated for breast cancer, for example, in our series. And you see here very low incidence. Lung also mostly in smokers, and chronic leukemia, it's not really related to the radiotherapy. Only in the old series there is chronic leukemia related to the radiotherapy. But also we have other therapeutic arms to have zero toxicity. I will show you an old technique of our institution. Initially began 67 years ago by François Baclès, who was one of the famous radiation oncologists treating breast cancer in Curie Institute. But here you will see the last publication of our team in this technique. Pretty easy, cheap, very nice for people as people from Egypt. And because I know that in Egypt as well, in some parts of France, there are people with large breasts. Pretty easy to put the patient in lateral position and to irradiate only the breast with anterior and posterior field. You can see here, and you can see also that the heart and the lung are very far from your irradiation fields. And please look at the dosimetric irradiation. You have here young patient, 66 gray to the tumor bed. Here is the tumor bed, and 50 gray homogeneous irradiation to the breast, and no irradiation to the lung and heart. And this is something that it's easy to do and not expensive and pretty useful for DCIS because we not treat here the lymph nodes. And look at our series, and it's very important point, and we'll discuss this in the invasive cancers also. If you evaluate the, sorry for this, I'm here. If you evaluate here the hard dose, it's very important to take care to see the treatment protocol, because if you have, for example, Hypofractionated radiotherapy as fast trial, here 28.5 gray in 5 fractions. You will have to the heart 0.25 mean heart dose for the right side, and you will have 0.5 for the left side. And these are statistics. And if you go to 50 gray plus 16, you have breast and boost, you will increase the dose to the heart, but you are still very low. And this technique is related to very low heart and lung irradiation. But you have to take care every time to detect in what protocol you are treating patients and evaluate the dose. And this is the alternative technique of breast irradiation in prone position. People from New York published this in 2004. Also not expensive, also 2 fields of irradiation. And it is also safe technique of breast irradiation also. But obviously there are countries, they have not alternative techniques. We have also possibility to propose respiratory control. At left side, you can see spirometric control. We began this in 2002 in our institution. And now we are doing mostly deep inspiration breath hold, the patient of the left side. But obviously this is just for the picture. It was a picture of Marianne Aznar, who has no lateral position technique, because this kind of patients with huge breast, I will treat her in lateral position, not with deep inspiration breath hold, which is more expensive. How to increase the efficacy of radiation therapy? The role of the boost in tumor bed in DCIS, what we know, difficult. There are retrospective trials. I will speak about the larger study, and also 2 prospective randomized trials. Here the situation. The only one published and the largest trial is with 4,000 patients, multicentric international, strict DCIS, breast conserving surgery and radiotherapy, median follow-up of 9 years. And we included, for example, our institution participated with 1,400 patients in this trial. And we studied everything, the follow-up, the size of the tumor, the grade, boost versus no boost, margin status, the presence of necrosis, ER status, use of tamoxifen. You can see here the patient's characteristics with median age of 56 years, without boost 35%, with boost 65%. About positive margins, there were only 4.1% of the patients. Grade 2 and 3 component, it means high grade, a lot of patients, most of them, 2,800. And the receptor status was known in 37%, because there are countries, as for example my country, we do not prescribe tamoxifen for DCIS because this is not routine practice. And here you can see that we looked at all characteristics of these tumors. And here you have the results. There were 253 ipsilateral breast tumor recurrences, about 6.1%. Of them, 47% were invasive and 53 new DCIS. Ipsilateral breast recurrence-free survival was close to 97% at 5 years, 94 at 10 years, and 91 and 15 years. This is important, and the other important thing I want to underline here is the recurrences in 118 patients as invasive events. Therefore, it's important to do the radiotherapy. But the question here was the boost. If there is boost benefits, and if you are looking here, there is been boost benefits, especially in patients younger than 50 years. There are also 2 prospective phase 3 trials interested of boost. 2 trials completed inclusions. The results are pending. and I will show you the design, but they are still waiting for the results because, as I said to you, there are very low rates of recurrence in this disease. The first international trial was conducted between 2008 and 2014, more than 1,200 patients, and the results are not yet available. This is just the protocol which was accepted to stratify between classic normofractionated radiotherapy and also hypofractionated radiotherapy. Our French trial was more classic, Ebis Trial. We conducted it between 2007 and 2013, and here we compared whole breast radiotherapy of 50 gray in 25 fractions with or without boost, and results are still not available. Very low rate of events, but we included 2,004 patients in this study, and we hope to have results in terms of the interest of boost in this disease. Can irradiation of the breast be omitted in certain low-risk DCIS group? And this was the question of SEER data in elderly, especially patients older than 66 years, breast conserving surgery, radiotherapy versus no radiotherapy, median follow-up of 5 years, and you can see that the authors selected the population of patients and said, if the patient is older, let's go to decrease the number of irradiated patients. And look at this. I think that as well in France, it's the same thing in Egypt. If you ask me, do you treat your mother with radiotherapy for DCIS? And my mother, she has 81 years, I will say, yes, I will treat my mother. Look at this. There is low risk group with higher recurrence rate as well as high risk group. The difference is highly significant. And they said, no, there is no benefit to do this omission of the radiotherapy. There are also prospective trials, and the most important initially was the Dana-Farber and Harvard Center trial with tumorectomy alone with large margins, more than 1 centimeter. Tamoxifen was not allowed. You can see they began to include the patients, and they stopped at 143 patients out of 200 planned because the incidence of the recurrences. You can see here there were 15.7% recurrences at 10 years and only 1.9 per year in the patients who were not irradiated. There was another registration trial also of DCIS. Here, this is the data published by Larry Solin, ECOG trial. It was used also tamoxifen. There was low risk group and high risk group. And here you can see the results. In both cohorts, there are recurrences, but higher recurrence rate in high risk group. And when we compare with the patients, because this is only registration trial, there were not patients with radiotherapy, but I will show you with the patients who are irradiated, who are at about 1% at 10 years, here you have very, very high increased recurrence rates. And the other, this is the reference. It has just been published last week, the actualization of this RTOG trial, phase 3 prospective low-risk DCIS. Can we omit the radiotherapy? Only low or intermediate grade, only tumors less than 2.5 centimeters, large margins more than 3 millimeters. They were stratified, the patients, by age, margins, size. You can see here the design of the study. And everything was taken in account. And obviously here, as in North America is a practice, we accepted normofractionated versus also hypofractionated radiotherapy. The first results were published at 7 years, and you can see here, this is the result at 7 years, 0.9% recurrences in irradiated patients versus 6.7% in non-irradiated patients. There was no difference in overall survival because in situ tumors. And when they reported the results at ASTRO 2018, and now you will see in the last publication, you can see that the recurrence rate in 12 years was 11.4 in no radiotherapy arm versus 2.8 in radiotherapy arm. Of them as invasive cancers, 5.8 in no radiotherapy. And this is important, that the invasive cancers are the patients who will have this risk to die by their cancer. Therefore, in conclusion, we can say that following breast-conserving surgery of DCIS, whole breast radiotherapy reduces the recurrence rate of breast recurrence by 50 to 60%. The effect is proportional, and no subgroups were identified where the radiotherapy could be omitted. Can we use biological and molecular markers? This is also important because last 2 years the literature exploded, and now we are looking in this population of patients. You can see p53 mutations, other mutations, the proliferation index. All this is now given by our pathologists as information. And because we know more about this disease, we compared with invasive cancers. DCIS are very close to invasive cancers. They are presented with the same genomic alteration and genomic profile. And therefore, it's important to think to these tumors as invasive cancer. It was shown that there are not specific alterations of DCIS compared in invasive ductal carcinoma. This is cancer. We cannot say that this is not real cancer because this is in situ. But there are lower frequency of alterations in IDC. Alteration in cancer driver genes, especially in high grades, are p53 mutations. Other mutations are shown. And we have some transcriptomic analysis, and we are looking now for more data about the regulation, for example, in some subclasses of this DCIS. Currently, some studies are in course in our institution, and we will follow very closely. Also, there are some biomarkers for patient selections of low-risk patients. HER2 overexpression was associated with increased risk of recurrence, for example, in one publication. In another, lower risk of recurrence was especially in receptor hormonal tumors with low proliferation and HER2 negative. There is increased risk of recurrence in highly proliferating DCIS reduced by radiation therapy, and this we have seen already. What we are doing now, look at this. We are doing now randomized trial. If you are interested to participate, I will give you the coordinates of my colleague, Dr. Alain Fourquet, who is my colleague and my neighbor by office. And we are trying to develop this phase 3 trial of omission of whole breast radiation therapy in patients with very low risk of DCIS. And the idea was to determine less risk than in the American trial. You can see here postmenopausal women older than 50 years, less microcalcifications, less necrosis, breast conserving surgical excision in good margins. But also this time, we will look at the receptor status. We will look also, and we will decrease the risk of recurrence using HER2. We will see also the proliferation index, and only when we have all these conditions, we will include the patient between whole breast radiotherapy or very close follow-up. And this is one open-label randomized phase 3 trial. Here you have the hypothesis, and we decided to put 666 patients. All pathologists are reviewed by central committee, and now we began to include the patients in this study. Therefore, I said to you, it could be also open to international participation. What about the role of endocrine treatment? There are some studies randomized to tamoxifen or placebo, and here you can see that the results were not so interesting to propose to all patients with all side effects of the hormonal treatment. The other thing was that here the tamoxifen was given to all patients with DCIS, but it was only shown to have benefits in patients with estrogen receptor positive tumors. There is also UK trial. The benefits was very small. There was also NCIBP B35 radiotherapy with double-blind randomization between tamoxifen and placebo versus anastrozole and placebo to find if the aromatase inhibitors are doing better than tamoxifen. And with the median follow-up was 9 years. Most of the benefit was seen in patients under than 60. And this is also important bias because we have seen that with only boost, we can obtain the same results. Therefore, in this population of patients, we look also about Ebis trial, which was also given and driven in our institution. We participated. We have seen that the difference between tamoxifen and anastrozole was not important, and only the side effects were important. But with median follow-up of 7 years, the benefits was very modest. Therefore, if we look in evidence-based conclusions, for DCIS, we can do excision alone, but the study have shown that important to consider the patients of really low risk, mostly in the clinical trials, because there is increased risk of recurrence. Excision followed by radiotherapy, we have level 1 evidence to support whole breast radiotherapy. Excision followed by adjuvant endocrine therapy, tamoxifen does not substitute for radiotherapy. Excision and radiotherapy and endocrine therapy, level 1 evidence for addition of tamoxifen, but the benefit is very small and the side effects are important. Anastrozole equivalent or better, but both have significant adverse effects. Therefore, as I said to you, we don't prescribe these treatments in DCIS. When we look the situation in more serious cancers, as invasive cancers, huge tumors, lymph node invasion, we have also this individual patient data in the Oxford analysis. And here, the publication of 2014, you know this very well, randomized trials of radiotherapy versus the same surgery, but no radiotherapy. And all these patients in this trials were treated by mastectomy and axillary lymph node dissection, at least level 1 and 2. Radiotherapy included the chest wall plus or minus the lymph nodes, more than 3,700 patients. You have 43,000 years of follow-up. You can imagine this huge data. Radiotherapy to axillary, internal mammary, and supraclavicular nodes. And after these results, we continue to say, okay, for 0 positive lymph nodes, usually we don't irradiate the lymph nodes, we will irradiate the chest wall if there are factors at risk. For 4 positive lymph nodes, obviously we will irradiate the lymph nodes with the chest wall. But for 1 or 3, we continue to discuss if there is a place of the radiotherapy, yes or no. And here you can see the analysis of N0 patients. I'm agreeing with the people from Oxford that after mastectomy and axillary lymph node dissection, for PN0 tumors, we have not seen really a difference in terms of recurrences and survival benefit. When we look at PN4 plus women, you can see here the significant benefits. In terms of recurrence, you can see 3 times more recurrences. Then any first recurrences we can decrease with 9%. And the most important thing is you can decrease the breast cancer mortality with 9.3%. When you are looking at Herceptin, trastuzumab was accepted with 4% overall survival benefit as reference in HER2 positive tumors. Look at this. We have with radiotherapy at 20 years, 9.3% benefits in patients treated for positive tumors. And when we look at 1 to 3 lymph nodes, you have still these benefits. And any first recurrence, you have 11.5%. And for mortality, you have 8% difference. Therefore, there is no question you have to treat these patients by radiotherapy. Then we can look also systemic therapy, because medical oncologists say, no, but this was without systemic therapy. And then Sarah Darby decided to do with systemic therapy, look at the difference, but patients irradiated or not irradiated, but they received their chemotherapy treatment. Look at this difference, still 11.7% in patients with 1 to 3 lymph nodes, and 7.9% in overall survival benefit. And this is speaking that radiation therapy is a part of this treatment, and there is no place of discussion in N-positive tumor. And then they began to say, okay, but probably for 1 lymph node, we don't need to do irradiation. No, they responded to this. These were the curves of my colleague from Oxford who presented at last meeting. You can see here, this is the same data, but they looked at only 1 lymph node involved, and you can see that we have for any first recurrence 11% difference between radiotherapy versus no radiotherapy, and you have 17% in local regional recurrence first curve. Then for the second, you have any first recurrence, and the third one is the decreasing of breast cancer mortality with 5% in 15 years. Therefore, when we look for these patients, we have absolute reductions at 10 years with 11.5%, 34.2 versus 45.7, 20-year breast cancer mortality reduction with 7.9, and we have proportional reductions of recurrence and breast cancer mortality. But then these were all trials. We have newer trials. We are doing better with the new chemotherapies, with the new techniques. Look at this actualization of with the new trials, and you can see here the patients with older trials, and then the patients with the newer trials, and you can see here very new trials as EURTC with 4,000 patients treated to internal mammary nodes, as well as MA20, as well as the Danish trial with pretty nice follow-up of 9.1 years. And once more, you can see that we have benefits in terms of any recurrence and breast cancer mortalities. Any recurrence in all trials, the benefits is smaller because obviously the techniques and everything, but also in the newest trial, you can see that we have highly significant difference, and there is benefits with the new techniques for irradiation of this subgroup of treatment. And once more, in the newer trials, you have this highly performant breast cancer mortality reduction from 19.1 to 16.3%. Therefore, with newest and older trial, it's the same thing. We can decrease the mortality. This is highly significant. Therefore, we have to do the radiotherapy. This is the meta-analysis, and it was shown that there is benefits in N+ patients. And this is the result using of the radiotherapy target volume, use of chemotherapy, endocrine therapy. In all cases, there was benefits in the patients treated by radiotherapy. And the conclusion of my colleague who presented this at San Antonio Breast Cancer Symposium in 2011 were that breast cancer mortality in older trials we have little effect because old techniques, because not so good protection of the heart, but the overall mortality is significantly increased because the side effects. But in the newer trials, this is important for us. Breast cancer mortality is reduced. It means that we have no excuses to not treat this population of patients. The overall mortality is significantly reduced, and absolute mortality reduction is the greatest, obviously, in patients with 4 and more lymph nodes. Therefore, in Europe, we developed our guidelines, and you know these guidelines of irradiation of the lymph nodes. Why it's important to speak the same language, to delineate together. It's important because the results of this other trial, conducted by the surgeon mostly, radiotherapy versus surgery of axilla in patients who are 1 sentinel lymph node positive. But attention, these were small tumors, T1, T2, and 0 clinically. But if the sentinel lymph node was positive, in this case, the patients were randomized between surgery, axillary lymph node dissection, or radiotherapy. This was multi-centric disease as exclusion criteria. As I said to you, small tumor, highly selected, not for every patient. Obviously, the radiotherapy fields were mostly 3D at this time, but currently we are doing better, and we know this. It was normofractionated radiotherapy. And the last actualization of this trial has shown that there is no difference in axillary recurrence at 10 years. Here you have the patient's data. The patients are pretty well equilibrated in between the both arms. The second primaries, you can see here, there was not really significant difference, very higher, a small difference between radiotherapy and no radiotherapy group. But this was the surprise, that there was mostly lymphedema in the patients treated with surgery. Therefore, now our surgeons, they don't like to do a lot of axillary lymph node dissection. But attention, you have just to show these slides and say, this was for T1 and T2 tumors. You cannot do this for inflammatory T4 tumor because this is bad for the patient. And yes, now we need more tumor definition and more new treatment and new techniques. And I will show you some slides at the end of my talk about how to treat the lymph node areas better with the new treatment modalities. Then some data between mastectomy versus breast conserving treatment. Also 4,000 patients, meta-analysis of Oxford. It was shown that there is no difference in terms of mortality. Therefore, the whole breast irradiation after breast conserving surgery is the standard. And here you have the last actualization of breast conserving surgery with 10,000 patients, really strong data about the reducing of the first recurrence, reducing of breast cancer death, and you can see any death is lower in breast conserving surgery and radiotherapy group. And N0 already we have this effect because after breast conserving surgery, it's important to irradiate the patient. We have this also in N+ patients, obviously with better survival benefit, very strong data with these take-home messages that we can reduce the rate of original recurrences by 70% with the radiotherapy. The rate of any recurrence as first event was reduced by 42 patients with radiotherapy. Original radiotherapy was associated with 18% decrease in breast cancer mortality after 5 years. And the effect of radiotherapy were proportional, independent from known risk factors as higher risk following surgery, higher benefit from the radiotherapy. How to increase the risk, the reduction of the risk? Look at this. This is boost versus no boost trial. This is the recurrence of all patients in this trial conducted by Europe. And you can see that there is benefit for all patients between boost or no boost. And this benefit is really related to age. Look at this, less than 40 years. You have to irradiate all patients with boost to the tumor bed. Between 41 to 50, you have also these benefits, and this is less benefits after 50. And in this population after 50, we can propose, for example, hypofractionated radiotherapy. And the side effects of this study, mostly reported side effects, was fibrosis at 10 years. Fractionation, for who we have to do hypofractionation, for who we have to continue to do normal fractionation radiotherapy. And look at all trials published in the literature. We have a choice of these huge trials with long-term results, because we will see some new trials with less long-term results. Start A at 5 years. The only arm of 39 gray in 13 fraction was with higher recurrence rate. Therefore, we do not use this. We use 41.6 start A, as well as 50 in 25 fractions, 40 in 15, very used in Europe because it's only in 3 weeks. We have the same recurrence rate as the classic shim. The same thing in the Canadian trial, 42.5 in 16 fraction. Usually the people from North America, they prefer 16 fraction. In Europe, we prefer the 15 fraction of start B trial. And when we are looking at toxicity, we have no difference between hypofractionated and normal fractionated radiotherapy in these trials. Local control. Can we treat all patients with hypofractionated radiotherapy? No, because the chest wall irradiation after mastectomy, it was only subgroup in the START trials. There is not sufficient statistical power. Lymph node irradiation was something, it was not used in our trials. In Consort trial, there was no boost, and only some patients had a boost in UK trials with a conventional regimen, not with hypofractionated regimen. Therefore, when we are looking at the guidelines, NCCN say that the breast should receive 45 to 50 gray normal fractionated radiotherapy, or 42.5 as the Canadian protocol. NCI in France say that we can do hypofractionation in all patients aged than 50, PT1, PT2, PN0, grade 1 and 2, receptor hormonal positive tumors, free margins. For the patients with N-positive disease and patients who need boost, usually we are using normal fractionated radiotherapy, or after 50, hypofractionated radiotherapy, one of these protocols, and then we do boost as in the START trial or as in the boost versus no boost trial, 16 gray in 8 fractions, or eventually 5 times 2 gray. And hypofractionated is not recommended if there is adjuvant chemotherapy, mastectomy, lymph node irradiation, grade 3, or lymphovascular invasion. But now we have protocols also with very hypofractionated regimens as FAST trial, 1 fraction by 5.7 gray per week. We know this because we have huge tradition for 100 years now in France. This is the series of Nice with 1 fraction of 6.5 gray in elderly, good local control, small risk of recurrences. Our series of Curie, also mostly in elderly, equivalent control, acceptable toxicity, and UK fast trial I have shown to you also with good results. 1 fraction per week, very nicely accepted by elderly. You can treat the patient in water or prone position, no toxicity, and this is very nice for old ladies. And now we have fast forward trial. We can do 5 fraction in only 1 week. Attention, we have only 5 years follow-up, very low level of information about the heart contents, about the technique you have to use. Therefore, for the moment, we began to propose this scheme for patients in elderly, and we are trying to do as prospective registration in our patients to have more information about this protocol. But it will be nice because you can see here the results are comparable, and we adapted already 26 gray in 5 fractions in 1 week for patients with irradiation to breast only. There is also this possibility to develop partial breast radiation techniques, but the only one which was really positive with enough power was the ESTRO partial breast irradiation trial, very selected population of patients, control arm breast plus boost, and high dose rate or post dose rate brachytherapy, reported at 6.6 years, very nicely equilibrated between both arms. And you can see here, no difference, but look at the curves, probably at 10 difference, the study will be negative. Therefore, it's important to follow at 10 years. Disease-free survival was the same in this highly selected population. And therefore, I presented to you this trial because the toxicity was acceptable, as well the arm of partial breast and the whole breast irradiation. But results only at 5 years. And look at this, you have here all literature about partial breast. Everything in red is reported as negative trials with thousands and thousands patients. In black, you have patients who are reported as positive in the trials, but at the same time, there was not significant power to report the difference, and there was important bias. The only one I've presented to you was GESR brachytherapy as partial breast. Therefore, in my country, the partial breast irradiation is recommended only in very low risk breast cancer patients or in the treatment studies. Here you have the recommendations of ESTRO as well as ASTRO, and you can see older patients, lower risk of recurrence, obviously N0, no DCIS, therefore it's important, our first part of the talk, no DCIS, and obviously no systemic treatment, because the systemic treatment usually is used in the patient with high proliferation rates. And at the last part, we'll see and we'll try to see how to reduce the toxicities and how we work in the next years with our future directions and technical considerations. We began in 2007 to try to do this 4D CT scan in selected patients to look at the movements of coronaries. We are working in the delineation of the coronaries for years now. Currently, we are creating, and you are very welcome to ask me, I will send to you the original publications about how you can improve your delineation of the heart substructures, because this paper of Sarah Darby, with very, very old trials, you can see patients treated between 58 and 2002. 58, you have seen my first slide, it was Röntgen therapy. Now we have wonderful accelerators, and only the patients who develop major effects. Here, Sarah Darby has shown that we have 7.4 4% increase per gray. Therefore, we decided to decrease the risk of cardiac toxicity. But when you are looking at the cardiac toxicity, you can see that the radiation therapy technique is only small part here about this toxicity. You have at the left side chemotherapy with all molecules we are using every day, targeted therapies as trastuzumab, pertuzumab, lapatinib. We have cardiotoxicity related to the patient and patient's risk factors, age, heart disease, tobacco, dyslipidemia, genetic reasons, stress. We have only this small part, and we can decrease because we can improve our techniques, move from 3D to MRT or lateral or prone. We can adapt the fractionation. We can control the respiration. And therefore, we have shown here, it was pretty funny for us with my resident to work if it's reasonable to speak about mean heart dose. Because mean heart dose, what it means? Something round at the middle of the thorax? No, there are a lot of cardiac substructures. And if you have patient at risk, you are interested by her substructures of the heart. And we need to delineate, and we have to do our atlases and to evaluate the dose to these structures. And obviously, as we discussed already, we can use respiratory control, MRT, sometimes electrons for chest wall irradiation, and why not protons? For example, this patient with very young patient, left side irradiation to the breast and lymph nodes, she needed this, and heart very close to the chest wall. Obviously, we have treated her, and it was in 2002 already, with spirometric control. We are looking now how to delineate the coronaries. This is a kind of CT scan we do only in patients at risk, and you can see all these beautiful vessels of the heart, and to delineate them, and you have give some information about the movement of these coronaries, and your physics departments can optimize your treatment plans. You can see here the work of my physicist between field in the field here for the breast at left side, and then electron and photon anterior field for the internal mammary nodes, but still those to the coronaries. When we are looking the distribution by tonal irradiation, you can see that we can spare better the coronaries, and my choice was the second technique in this case. Now we are working about the use of protons, how to select these patients, because we have only 3 machines in France, and it's not enough to treat breast cancer patients. In 60,000 patients per year, we have treated only 3 patients for the moment with protons, but these are very young patients. You don't want to irradiate the contralateral breast. You need to irradiate well, for example, the breast, boost, and lymph nodes. This case, the protons are useful. You want to decrease the dose to the heart because the patient is already with heart disease. You can use protons. Therefore, we are working in this direction. And as I promised to Khaled, I've taken 1.5 hours, and now it's your turn for the questions. Thank you for your attention.
Thank you, Julia, for your comprehensive and detailed presentation. And now we can. Thank you. And if you have any question, please feel free to ask Julia or write your question in chat. Can I start with a question for you, Julia? What is your standard fractionation at your department? In Germany, we are starting to treat all of patients with hypofractionation.
In France,
fractions.
In France, for example, because as I said to you, we have a very long tradition with the works of young patients. We use for all patients younger than 50 years normofractionated radiotherapy, 50 gray in 25 fractions, to breast and lymph nodes or chest wall and lymph nodes. And under 50, all patients with breast conserving surgery will receive boost to the tumor bed, 16 gray in 8 fractions. This is 50.
Okay.
Between 50 and 70, we are doing for all patients, as you said, 40 gray in 15 fractions, but we can add boost if there are risk factors, as we discussed, DCI as the high grade, or lymphovascular invasion, or grade 3 tumors. These are factors at risk, and in these cases, we can add boost after 15 fractions of 2.67.
Okay.
And after 70, we discussed to introduce largely also the fast forward protocol. For the moment, we use also 40 in 15 fractions, but for the moment, this is only a discussion. The first patient were older than 75, but it's very nice tolerance. This is irradiation used only for breast irradiation. But for example, in our country, all patients who will receive lymph node irradiation, they are treated with normofractionation. We have national study Hypo-G trial, and we will report our results 15 fractions versus 25. And I hope that the results are positive, and we can use also hypofractionation for the lymph node irradiation. For the moment, we use this only for older patients. In Germany, the only thing that I don't understand is how you can respect your degrow deadlines of the hard dose.
Yeah, I don't understand.
Because you have to treat all patients by protons to obtain doses lower than 1 gray left side breast cancer patients.
Yes, exactly. Yeah. We are waiting your study results, and we hope it will be positive results for all of us.
Yeah.
I got
Hypo-G, preliminary results were presented last week at ESMO, but mostly in the terms of lymphedema, we have not found any difference between two groups, and probably an efficacy we'll have in 2-3 years results. Yes.
Okay, very nice. We received a question in chat. What is the optimal time for adjuvant radiotherapy, Julia? Especially if the patient delayed to start chemotherapy.
Very good question. We, especially during the COVID epidemic, it was very important to detect how we can select the patients. All patients who will receive chemotherapy, they have their radiotherapy in the 4 weeks after the end of the chemotherapy. We do not interrupt the trastuzumab, for example, we are doing at the same time. Because we have shown that we are not more toxic in association. On the other hand, the patient who will not have the chemotherapy treatment, the patients who are with in situ tumors, say it's between 4 weeks and 3 months. And we know that only in situ tumors we can go to 3 months. But in all invasive cancers, usually we try to begin between 4 to 8 weeks after the surgery.
Okay, this was a clear answer from you, Julia. Do we have any other questions? Yeah, this was our last question, Julia. Before we close, let me just summarize the main points from your presentations. Julia started with the epidemiology and risk factors of breast cancer disease. Then she went over the DCIS treatment, and she talked about invasive carcinoma treatments. Finally, we got some points about the future directions. It's a near future in radiation oncology field. And right, that's all for today's meeting. Thank you, Julia, for your time, and hope see you in person soon after Corona pandemic. And
thank you very much.
Have a nice weekend. Thank you
and
so
if you
much.
have any questions, you have here my mail.
Yes.
Please use it. Thank you very much. Have a nice day. Bye-bye.
Thank you. Bye-bye.